clinical digital twins. I'm Fredrik Ahren. I will be sharing this session together with.
I'm Benjamin Hofner. You have seen me in the panel of the last session, and I'm, as said, a regulator at the Paul-Ehrlich Institute.
So without further ado, I'd like to introduce our first speaker, Andreas Brandt. He has a diploma in mathematics, PhD in genetic epidemiology. Since 2010, he's a statistical assessor by BfArM.
Okay, thank you very much for the introduction. So, oh yeah, then I will use this one. Yeah, okay. Yeah, as you're used to it, until the disclaimer. Okay, first of all, as in the outline of my presentation. So first of all, I want to highlight some key issues from the EMA guideline on adjustment for baseline covariates. Then I want to talk about new approaches for adjustment for covariates that include the development of synthetic prognostic covariates for adjustment to increase the efficiency by reducing variability, with a special focus on one approach called ProCova. And then I want to talk about some of the challenges by these new approaches. So first of all, with regard to the guideline on adjustment for baseline covariates in clinical trials of the EMA. So the latest revision of this guideline came into effect in 2015. So it's now, we could say it's already quite old, and but still it has some. The principles in it are worth to think about and consider. So first of all, I would start with the general guideline requirements for covariates in the primary analysis. So the guideline requires that all covariates included in the primary analysis must be pre-specified. So there should be no covariates included in the primary analysis that are measured post-baseline, and there should be no treatment by covariate interactions. So, but the guideline also gives some recommendations on covariates to be included. So first of all, it says that there should be a justification for including each of the covariates. And of course, so the main reason and the main justification to include a covariate is evidence for strong or at least moderate association between the covariate and the primary outcome measure, because we all know that adjustment for such covariates will improve the efficiency of the analysis. But what should also be considered in the analysis are stratification variables that should be included either by stratification or adjustment. So the principle is always analyze as randomized. And the guideline also recommends to include no more than a few covariates. So, and the justification for this is that it is safer to pre-specify a simple model, so it's more likely to be numerically stable. The assumption of the model are easier to validate, and the generalizability of the models may be improved. So this was what covariates should be included, and with regard to how to include the covariates, the guideline recommends that without a prior knowledge, a simple functional form should be assumed when we have a continuous covariate. And it also says the validity of the assumptions must always be checked when assessing the results, which is particularly important for generalized linear or nonlinear models. So now the guideline has also some what I would call important messages. So I think one of the key sentences in this guideline is that simply producing smaller p-values does not provide the sufficient evidence or convincing evidence to produce a clinical useful effect. So there are important considerations beyond the p-value for primary analysis. This is, of course, the size of the treatment effect and the precision with which it can be estimated, but it's also the consistency or the assessment of the consistency of the treatment effect across levels of covariates. So we have to be able to make a benefit risk assessment based on which also includes a subgroup analysis. But now we live in the era of big data, digitalization, and artificial intelligence. And of course, the question is, how can these tools be used to improve the efficiency of clinical studies? So different proposals have to be made. So these include borrowing approaches. So this means directly using external data in the analysis of a study. This is often done by Bayesian approaches. But we have also seen proposals to enrich studies based on predictive covariables. So that means that one tries to predict for example, the placebo response, and then the patients with a high expected placebo response are either excluded from a study or downweighted. But these approaches come with concerns with regard to type 1 error control. So this is not given when external data are used. And also with regard to external validity, so the question is to which target population do treatment effects from enriched study populations generalize. So the alternative about what I will mainly talk in the rest of this presentation is to develop new prognostic covariates, or sometimes also called synthetic covariates, and adjust for these in the primary analysis. And these prognostic covariates are developed based on external historical data, and this comes with a promise to improve the efficiency of the study while preserving the important properties of classical analysis, such as type 1 error control and asymptotic unbiasedness. So one specific of these approach that gained recent attention is the so-called ProCova approach. And this is because last year the CHMP published a qualification opinion on this approach. So what it is ProCova about? So the idea is to develop a prognostic score for continuous outcome under control based on a historical data set that is independent from the study data. And then the reduced variability can be used to account for the prognostic score when estimating the sample size of a new trial, or potentially a smaller sample size could be used. And when the study is analyzed, the prognostic score is applied as a covariate in an ANCOVA model in the new study. So this procedure could utilize a prognostic score generated by any prognostic model. So this can be a mechanistic model. These could be linear and nonlinear statistical models. So models with interactions between covariates or machine learning based methods. So what is important to note is that the prognostic model development was out of the scope of the qualification procedure. So the qualification procedure only covered the first 3 steps. So now what are some key issues from the CHMP qualification opinion? So this qualification opinion says that ProCova could enable increases in power or precision of treatment effect estimates in RCTs with continuous outcomes. And so the method can be regarded as a special case of ANCOVA that shares the properties of type 1 error control and asymptotical unbiasedness of the treatment effect. But whenever it is intended to use this approach, it needs to be justified by explaining that the advantage over using no adjustment at all or classical adjustment with a single covariate. So before I go on, just some remarks on PROCOVA. So as for any qualification procedure, there was a public consultation phase, and a comment that was received during this consultation phase was that the idea to develop prognostic scores and adjust for it in an analysis is actually not new. Of course, this is a fair comment, so this is true, but nevertheless, so PROCOVA, they made considerable efforts to write everything down in a systematic way. And PROCOVA is not the only approach in this regard that was discussed, or with similar ideas. But there are some differences. So all of them have the general idea in common, but there are also some differences. So some propose only to increase the efficiency with these approaches, or not to reduce the sample size. And some also have a broader scope than PROCOVA, so they are not restricted to linear models. And the CHMP emphasized that it is not intended to single out the PROCOVA approach as the method to be used, but it is only one approach that could be used. So now, what traditional principles from the guidelines that are presented before are now in some way challenged by these new approaches? So in classical analysis, we stratify and or adjust for clinically important covariates. So we analyze as randomized and ask clinicians what covariates should be considered and include them. And now we adjust for prognostic score, either only for this prognostic score or on top of some single covariates. But this prognostic score has no direct clinical interpretation. So as I said before, the guideline recommends to include no more than a few covariates in the analysis, but now the new approaches include a prognostic score that cover the information from many covariates. We have usually a simple functional form for the relationship between covariates and outcome, but now the prognostic score is based on a complex prognostic model that is more or less well understood, or may even be a kind of a black box. Oh, sorry, no, I jumped. Yeah, okay. But of course, our traditional principles are not a value in itself. So, but they are there for a reason. But of course, when there are good reasons for it, we can also discuss why it could be changed. So, what are the pros and cons of the new approaches? On the pro side, of course, there's a potential gain in efficiency. And as we add only one covariate to the analysis, the concerns with regard to a loss of decrease in freedom and with lack of numerical stability are less relevant. But we have all this also comes with some disadvantages. So the first of the one is that adding synthetic covariates on top of classical adjustment may introduce collinearities. So we may not be able to estimate the influence of the usual of the other covariates in the usual way. And as I said, the prognostic score may result from a complex, poorly understood model, or even a black box. So this raises a question, and for how far are the results from such an analysis reproducible? And it also comes with potential concerns with what is the interpretation of what we actually estimate. And this also concerns the interpretability of subgroups. So as I said before, we always need to have not only the primary analysis, but other considerations are also very important. So is the interpretability of subgroup analysis endangered? So for example, the ProCova handbook even advises against using the same model to explore subgroup by treatment interactions due to concerns of bias. So the general and most important question that we need to discuss is, do we sacrifice clinical interpretability for small p-values? And yeah, I think this is not really finally understood, but some considerations that can be made. I think this can be really different when we have linear models, for which, for example, ProCova was developed, and nonlinear models, or generalized linear models. So first of all, when we combine linear models with these newly developed prognostic covariates or synthetic covariates, in linear models, so these are unconditional models, so the targeted treatment effect, or that means the estimate, is independent from covariates. And the ANCOVA does not require that prognostic models is correct, that the prognostic model for the covariate development is correct. So the properties, type 1 error control and asymptotic unbiasedness still hold even when it's misspecified. But there may be concerns with interpretability. So we have a covariate that we do not really understand, and there are concerns with the interpretation of subgroup analysis. But here it could be asked whether there could be benefits of such approaches, and maybe there's not much harm, but I think this still needs to be better understood. But I think the situation is quite different when we consider generalized linear and nonlinear models combined with such prognostic or synthetic covariates, because frequently used generalized linear models or nonlinear models provide conditional treatment effects. So this includes logistic regression models and Cox regression. So in this case, we have a conditional treatment effect, so which is roughly speaking the average of treatment effects for patients with the same covariates. And in this case, the targeted treatment effect of the analysis is dependent on covariates. And I think, so the interpretation, what we actually estimate, depends on what we condition. And when the covariate is poorly understood, we actually do not really understand any longer what we actually estimate. So this means that we do not really understand any longer what is estimated. So this requirement that it needs to be interpretable is not fulfilled for when a synthetic covariate is used. So I think currently this is not really recommendable. For other generalized linear models or nonlinear models that provide unconditional treatment effects, the situation may be different, but I must confess I'm not an expert there. But we have always to keep in mind that the aim to use synthetic covariate or more efficient analysis is not a sufficient reason to use a specific estimate, but we always need to use the estimate that is most relevant. And the last point that may be of interest in this regard is, what I would say is transparency issues. So proposals have been made to us to keep the prognostic model, to derive the prognostic score confidential. So that means the sponsor of a study is only provided as a prognostic score, but he doesn't actually know how it was derived. And so this is also a problem during regulatory assessment, because I think all relevant stakeholders, so sponsors and regulators, and also the public need to understand the analysis that was conducted, and especially in case of these nonlinear models. And also a big question is, as always today, who has access to data? So at the end, there may be issues with data protection, informed consent, and the question who owns the data that may make the training data sets not accessible, so that it is finally not really transparent how the prognostic scores are derived. So, sorry, I think I was at the end of my presentation. Yeah, and I thank you very much for your attention.
So thank you very much, Andreas, for a very interesting and thought-provoking presentation. I think we'll save questions to discussion at the end. We will have plenty of time for that. And with that, I'd like to introduce our next speaker, Courtney Shipman, who is a principal statistician at Genentech. She started there 4 years ago after graduating from the University of California, Berkeley. She shares her time between being a study statistician and supporting trials through exploratory data analysis and methodological development. So over to you.
Thank you. Can you hear me all right?
Yes.
Perfect. And can you see my screen? All right, I'll take that as a yes. Thank you so much for inviting me to talk today. I'm very excited to share this presentation my colleagues and I have put together on the strategic considerations and value of covariate adjustment. I hope to just cover how we believe covariate adjustment can be done rigorously and practically as study statisticians on clinical trials. So I think it's important first to just start off by clearly defining the scope, what we mean by covariate adjustment. We mean using prognostic baseline variables to improve precision and power when estimating marginal average treatment effects. We focus on the standardized estimator, what has been referred to as the standardized estimator in literature. And that's just simply where you take treatment arm means that are estimated as the average of predicted outcomes that come from some working regression model, like GLM. And that working regression model adjusts for baseline covariates. So this standardized estimator is applicable to both continuous, binary, and count outcomes, so not just continuous outcomes. And there's a very clearly defined marginal average treatment effect, which is just some contrast of those treatment arm means, for example, the difference, but it could also be, the ratio. Just want to point out that this is exactly the same estimand or targeted parameter as an unadjusted analysis. This is not a conditional analysis where we're trying to enable personalization in any way. But the focus of this talk is simply around estimating marginal average treatment effects. And the amazing thing is that it's asymptotically valid, even if this working regression model, this GLM, is misspecified. And that's why we like the phrase model assisted, not model dependent. We want to point out that there's a beautiful historical context of covariate adjustment that reaches back many decades. For example, Cochrane has his discussion of regression techniques for increasing precision in sampling in his sampling techniques back in 1977. There's a great paper from 2001 that we love, talking about the consistency of ANCOVA, even under model misspecification. Friedman has a very well-cited work where he works under the Neyman model, where he does actually make some cautious statements about covariate adjustment around biasness and around it hurting you. And that's back in 2008. And then there's a bunch of great work within the past decade and a half from the targeted learning literature around using covariate adjustment with these generalized linear models, for non-continuous outcomes like binary outcomes as well. Winston Lin has a fabulous paper from 2013 where he kind of generously straightens out some of Friedman's critiques, and he's working under the Neyman sampling framework. And then more recently, we see more discussion, even from companies or from industry like ourselves, leveraging things like machine learning within for covariate adjustment, which is very interesting work. So there's a lot of historical context for our discussion today. So what I would like to do is to kind of begin this discussion around how we think covariate adjustment should be done rigorously by study statisticians. I'll talk about strategies for how you should determine which covariates to adjust for in the working regression model. So first and foremost, one of the most important points we want to emphasize is really that it's important to maximize the value of data. So this means that you should really try to leverage whatever independent data you have at hand. So that means historical trial data, observational data that you have, to try to find the most promising supercovariates for covariate adjustment. So that term supercovariate simply means some multivariate function of covariates. So what does that mean specifically? That means with this independent data that you have at hand, you can use that with a smart data handling strategy to develop and select a prognostic model. And then in future upcoming trials, you apply that pre-specified prognostic model to patients that are coming in the new trial, and then you adjust for whatever that predicted outcome is as a supercovariate. Ideally, this should be, the predicted outcome from that prognostic model should be, or the prediction from that prognostic model should be a predicted outcome, but it can be something related to the outcome. So when we're talking about this prognostic model that's producing this supercovariate, we do want to point out that the goal really should be to find a prognostic model that has minimum complexity with maximum performance. So in our opinion, we always think that some simple benchmark model with minimum complexity should be developed so that you have a comparison with whatever more complex, maybe it's some machine learning model, a deep learning model. You have some comparison of model performance. Often we see complex models shown and their model performance shown, but we have no idea how it compares to just a more simple benchmark model. Maybe the benchmark model often performs just as well as a complex model. So I'm using this word complex. What characterizes complexity? Well, it's of course the number of features. If you have a lot of features in a model, that puts a lot of burden on study teams to clean and QC those variables. It could also be the type of features. So features are very difficult to collect or are invasive for patients, or maybe they're costly. So for example, cerebral spinal fluid biomarkers or PET scans, these types of complex features can add complexity to your model. And then, of course, maybe what we all think first when I say complex model is the type of model. So is it a black box model, some kind of deep learning model, or is it an additive model? We really have to consider how easy it is to deploy these models in practice. And of course, interpretable models are preferred generally and may be more robust. We think this is a great quote. Simplicity is a great virtue, but it requires hard work to achieve it, actually, and education to appreciate it. And to make matters worse, complexity sells better. All right, so let's say perhaps you have multiple supercovariates that you're considering. And I talked about, using independent data to select which supercovariates to use. Well, how do you do that? So you should use some metrics that are intuitive for yourself and for study teams to understand, exactly what the benefit is of adjusting for those supercovariates and to quantify what the expected benefit is. So one intuitive metric that we think study statisticians should be using is what we call the effective sample size increase. Notice that we call it a sample size increase and not a decrease, and we'll talk about that a little bit more in a couple slides. So I will be showing effective sample size increase formulas and examples just for continuous outcomes. We're currently working on developing similar metrics for binary outcomes. So what does the effective sample size increase tell you? Well, let's say you have an ESSI estimate of 40%. That means you can tell your team, hey, look, this ESSI estimate of 40% means precision and power gain from adjusting for this supercovariate is equivalent to running a 40% larger trial. So we think that that's quite an interpretable metric that can kind of call out the benefit of and quantify the benefit of adjusting for a covariate. So it turns out under certain assumptions, the ESSI only depends on two parameters. I'm showing here a very simple formula for how to calculate the ESSI, and it just simply relies on the correlation in the control arm. So here, if you look at this graph, for example, with predicted outcome or your supercovariate on the x-axis and observed outcome on the y-axis, blue is the active treatment, black is the control arm. ESSI is just a very simple function of the correlation between the supercovariate and the observed outcome in the control arm in black, and that also the correlation between supercovariate and observed outcome in the active treatment arm. It's just simply 1/1 minus the squared average of those two correlations. And of course, you can see as the correlations increase, your effective sample size increases. If you're interested, so again, this formula is calculated under various assumptions, but if you don't want to make those assumptions, we have general formulas available as well that fit for any possible scenario. Okay, so those are the ingredients needed to estimate ESSI. The correlation under the control arm can be estimated using the independent data that you have at hand from historical trial data or from the observational data. But how do you estimate the correlation in the active treatment arm? So there's some ways to do that. And one is to assume one of two plausible treatment effect scenarios. So one quite plausible treatment effect scenario I'm showing on the left here, which is a constant absolute treatment effect. On the x-axis is the supercovariate or predicted outcome. On the y-axis is the observed outcome. And again, I'm showing the two treatment arms in this case. There's a constant absolute treatment effect as you vary across the supercovariate or the predicted outcome. That delta, the difference between the expected outcome under control and active treatment, remains constant. So it turns out that if this is the treatment effect scenario you want to assume, the correlation in your active arm actually equals the correlation in your control arm. So if those two things are equal, you can plug those in. Then in your ESSI formula and actually get an even simpler formula for your effective sample size increase. Now, maybe you don't want to assume that, and you think it's more likely that you have a constant proportional treatment effect. So that means as you vary across your predicted outcome, the delta, the difference between the expected outcomes is actually changing, as you can see here, but proportionally it's constant. So this is a scenario where there's treatment effect heterogeneity, right? That delta is changing as a function of your supercovariate. In this particular scenario, that implies that the correlation in your active treatment arm is less than the correlation in your control arm. And in fact, whatever, let's say the correlation in the active treatment arm, or let's say the expected outcome in the active treatment is 60% of your expected outcome in your control arm. That means the correlation will be 60% of the correlation in the control arm. So you can use that, whatever you're assuming that constant proportional delta is, you can use that to calculate R active, and again, plug that into your ESSI formula. But importantly, the main takeaway here is when you assume there's treatment effect heterogeneity, so when that delta varies as a function of predicted outcomes, that is going to impact your expected gains from covariate adjustment. If there is treatment effect heterogeneity, that reduces the benefits of covariate adjustment as seen, as demonstrated by this decrease in effective sample size metric when the correlations in the active treatment arm are lower. So that's very important to keep in mind when thinking about what to do with sample size. So for these reasons, we have some recommendations that we tend to follow internally. For phase 2, covariate adjustment we see is all about improving decision-making. So we know that from the previous slide, ESSI depends on whether or not the treatment effect is heterogeneous across that supercovariate. In a worst case scenario, you have 0 effective sample size increase expected. So due to the risk of underpowering, if no prior data is available on what the treatment effect scenario is, we do not generally recommend reducing sample sizes in phase 2 because of adjusting for a supercovariate. If you do decide to reduce sample size, be sure to communicate the risks to the study team, that it's not a surefire bet that you get, huge gains in precision from adjusting from the supercovariate, because you don't know exactly what that treatment effect scenario is. Now, in the phase 3, you can now supplement the ESSI estimates that you had previously from the independent data. You can now supplement it with direct ESSI estimates from the phase 2. And you have more of an idea around what the treatment effect scenario is. So you could consider reducing sample size in a phase 3 as a result of adjusting for a supercovariate. However, still be aware of the risks and make sure you have enough sample size, of course, for things like safety databases and subgroup analyses. And make sure to communicate to the team that there is still noise in these ESSI estimates and study-to-study variability. Okay, so that was around how to determine which covariates to include. How about this form of the working regression model that I was talking about, this generalized linear model? And again, we really like that term working regression model because it emphasizes that it's kind of just a workhorse for getting your predicted outcomes. It does not have to be correctly specified. So as Andreas was talking about, adjusting for too many covariates in your working regression model relative to your sample size could invalidate your analysis. So our recommendation, and this is just for continuous outcomes, is to follow, don't go beyond your model budget. So model budget is the number of allowable model terms, excluding the overall intercept. So we are kind of pulling from the prognostic modeling literature and practices, and giving it just a general just a rough starting point for your model budget for continuous outcomes. It should probably be no more than 5 to 7% of your total sample size. Once you determine your model budget, it's important to spend your model budget wisely, especially if your model budget is tight. So how do you do that? That means really just prioritize which covariates are the most prognostic and use those ESSI formulas. And I'll talk a little bit more about this in the next slide, but that may mean prioritizing features that or you really believe are prognostic over things like stratification factors, which may be there more for historical reasons and not necessarily the most prognostic. Utilize supercovariates when your model budget is tight. If you don't have a lot of sample size to include multiple covariates, you could just use some multivariate function of those covariates. However, we do just want to point out that if the model is some simple linear model and you have your model budget allows, you can, of course, just include those individual covariates in your working regression model and refit. And there are many people, and I think rightly so, it's very reasonable, who prefer that, that technique. Make additive models as opposed to models with treatment by covariate interactions your default choice, and avoid dichotomedia that's forced by stratification, which will increase your precision going with original forms of the covariates. All right, this slide, I want to just call out that we know that this recommendation may be controversial, especially given what we heard Andreas say about adjusting for stratified randomization. But we know that covariate adjustment, assuming simple random sampling, is consistent, and inference is at worst conservative, okay? So to remove conservatism, there's been some interesting work by Wang et al. That I have referenced here, that what you could do is add all indicators and all treatment by indicator interactions for your stratification factors. So that means if you have 4 regions and you have sex, that's going to be 8 different strata that you have to include indicators for and treatment by indicator interactions, okay? So we believe that this is a somewhat inefficient way to capture prognostic value, and importantly, just leads to too many model terms that will go beyond your model budget. So instead, we recommend using covariate adjustment and following our previous guidance of spending your model budget wisely, which means prioritizing, and all of those other points about spending the model budget wisely, but for example, prioritizing covariates that you believe are really going to add prognostic value over stratification factors. And some of those may be stratification factors, but just lump them all together and treat them all the same, and just prioritize those that you think are going to be the most prognostic. So this, again, may be a somewhat controversial recommendation, but we think it's important to avoid adding unnecessary complexity to the analysis. And also, you don't want to go beyond whatever your model budget is for that working regression model. I'm going to end by showing a really interesting example from ophthalmology that we have internally. So geographic atrophy is an eye disease. If you look at pictures of the eye, you can actually see the lesions, and these lesions lead to blurred vision and eventually blindness, and it's a progressive disease. That disease progression is actually quite linear. If you see here, I'm showing some patient trajectories. And how do you kind of assess disease progression? It's via the GA lesion area. So I'm showing here fundus autofluorescence images, FAF images, which I'll refer to later. So this growth rate in the GA lesion area is an approvable endpoint, and this is what we're going to be modeling. So our objective is to develop models that predict this primary endpoint using baseline information, and then use predictions from those models as supercovariates. So we had a very rigorous data strategy and a lot of really lovely curated data to work with internally from previous trials. So what I'm showing here is how we split up data from Spectri and Chroma, which are phase 3 trials, and also Proxima A. We mix those together and split those up into training and testing set. You can see the sample sizes are quite nice and workable, so we can build some interesting models here. And then we had a completely independent holdout set with 2 other data sets, Mahalo and Proxima B, other trials that we had run internally. I think even Proxima B has slightly different inclusion criteria, which is kind of nice. So that's the data handling strategy, lots of data to work with. And what models are we building here? So I'm going to show results for 2 models that we use to create a supercovariate. One, importantly, is that benchmark model I was talking about, this benchmark feature-based model, where we use known prognostic factors, lesion characteristics from reading centers, and functional outcomes. So we build this simple linear regression with just 5 features as our benchmark model. Then we have this end-to-end deep learning model that's just built on one single FAF baseline image. Okay, so that's all it is that we feed in a patient's baseline FAF to this deep learner, and we get a predicted GA lesion area growth rate. So these are the two models, one quite simple and for many different reasons, and one more complex. Okay, so what I'm showing here is model performance assessed on data sets that are in the holdout data set, and then also these completely independent Mahalo and Proxima B trials. So you can see here I'm showing right away the squared correlation and control arm. Here we're assuming a constant absolute delta. So that's why my ESSI formula is just going to collapse into, assuming the two correlations are the same. You get 1/1 minus R squared control. And so what you can see then is that we translate the R squared into the effective sample size increases using that formula versus just an unadjusted analysis, and then versus the deep learner versus the benchmark. So if we look at the effective sample size increases versus unadjusted first, you can see right off the bat, the benchmark model does add value. You're seeing effective sample size increases of 19%, 50%, and 34%. In these kind of test and holdout data sets. So that's nice. The simple model does indeed add value, but kind of amazingly, when you look at this deep learning model's effective sample size increase, it kind of blows it out of the water, and you're seeing huge effective sample size increases if you were to adjust for the super covariate. It almost doubles your trial size. So that was a really kind of interesting example for us where indeed a more complex model is kind of adding, definitely adding value above a simple regression, simple model. We just want to kind of end here with two thoughts. One is that we had in mind this kind of recent reflection paper on the use of AI in medicinal product life cycles from the EMA. And we really liked their discussion of how artificial intelligence should be implemented based on risk, right? It's very important to consider risk if you're in a high risk scenario or low risk scenario when implementing things like machine learning and artificial intelligence in clinical trials. We kind of considered this scenario of covariate adjustment somewhat low risk. But of course, models should be built on data external to the trial, as I've already said, and things should be clearly pre-specified in the SAP. And I think it's very important to have appropriate documentation on all of the data pre-processing and model development and deployment. So some concluding remarks here. I know that digital twins appears in the title of this session, but we believe covariate adjustment is not synonymous with digital twins. Covariate adjustment is all about predicting point estimates. It's all about finding those predictions that have the highest squared correlation with the observed outcomes. It's not about, generative AI or generating distributions of outcomes, which is kind of what more digital twins is all about. Internally, we use mixed models a lot. So MMRMs are quite common method of estimating marginal average treatment effects. There's a really nice paper shown here at the bottom, referenced here, that just cautions, be really careful to include appropriate interactions with covariates when using MMRMs to make sure you get those precision gains. And finally, in light of recent methodological developments, we wonder if we're going to pose the question, should the 2015 EMA guidance document for covariate adjustment be updated? So for example, around things like including treatment by covariate interaction terms or correct model specification and assumptions. So with that, I will end by saying thank you so much to my colleagues, Christina Rabe and Mike Friesenhahn, who we've worked together on all of this covariate adjustment topics and for helping me put together this presentation. And please, if you're interested to learn more about what we've been working on internally, we do have a public blog and one post currently we have on covariate adjustment where you can find all those ESSI formulas and in more detail around all of the topics that I discussed today.
So I would like to thank Courtney for a very nice and clear presentation. I know we have a few questions in the chat, but nonetheless, what I would like to do is to have the third presentation and then have the full time dedicated for the discussion at the end. So with that, I'd like to introduce our third speaker. Daniel Rubin is a statistician at the US FDA. He has focused on the design and analysis of clinical trials for anti-infective drugs. He has worked on multiple FDA guidance documents, including recently the FDA's guidance on adjusting for covariates, so perfect for today's topics. So with that, I would like to hand over to you, Dan.
All right, well, thank you very much for the introduction and the chance to participate in this conference. I wish I could be there in person. Could you just quickly confirm that you can hear me and see my slide?
Yes, we can.
Thank you. So here's my disclaimer. What I'd like to do today is first provide a little bit of a history of our guidance from the FDA on adjusting for covariates and randomized trials of drugs and biological products, and specifically focus on the changes made in the finalized version of this document that we released earlier this year. And then I'd like to provide a high-level summary of recommendations in our guidance document. And finally, I'll conclude with some remarks about data adaptive covariate adjustment. So this guidance project from us began in 2019, and the overarching motivation was that we felt that covariate adjustment appeared to be somewhat underutilized in randomized trials because it can provide precision and power gains, and moreover can do so without relying on very strong statistical assumptions. So in 2019, our first draft guidance just dealt with adjustment with linear models and outcomes measured on a continuous scale. In 2021, we released a revised draft guidance that provided more detailed recommendations and also expanded the scope beyond the linear model case. And then based on comments received, we finalized our guidance in May of this year. And you can find the link to this document here on this slide. So what I'd like to do now is summarize the changes made in our version of the guidance from this year compared to the previous iteration. And this slide will probably be most comprehensible to those in the audience who have some familiarity with the document. But if you're not in that category, don't worry, because I'll soon will summarize the guidance recommendations. So the main set of changes made were adding discussions of additional topics, as well as additional details and reference methods. So we've tried to clarify how the framework in our guidance aligns with the estimand framework of ICH E9R1. I'm going to say a little bit more in a second about the newly added guidance comments on selecting covariates. On sample size calculations, we've added some material, and this is an area where we give sponsors a fair amount of discretion. And in particular, it's acceptable to the FDA for this guidance if one is performing a covariate adjusted primary analysis to either base the sample size calculation on the planned adjusted analysis or on an unadjusted analysis, and the unadjusted sample size would typically be larger and more conservative. Now, the guidance makes the comment that permutation or randomization tests are acceptable with covariate adjustment to test the strong null hypothesis of no treatment effect for any subject. And on stratification, as you know, it's fairly common for clinical trials to stratify the randomization by selected baseline covariates. But unfortunately, we've noticed that in the analysis, and particularly computing standard errors, it's fairly common for this to be ignored. And this doesn't create any problems with bias or type 1 error rate inflation, but what it does do is make the analysis more conservative than it needs to be. So typically, we recommend that the analysis accounts for stratified randomization. Now, in our previous iteration of the guidance, we had referenced one paper that discussed this problem, but to clarify that that reference was more for illustrative purposes than prescriptive purposes, we've provided a more general discussion and referenced additional methods to clarify that we weren't recommending that one kind of method be used across the board. And a question we often get about this topic is whether if one is placing a stratum variable in an adjustment model, it's acceptable to use the as randomized value of the covariate, meaning the value that was used in real time to implement the stratification, or some type of actual version that's been subject to adjudication. And our thinking on this is that in principle, either type of covariate is acceptable as long as the method is pre-specified and it's considered a proper pre-randomization covariate. Now, a topic I'm going to get into in a second is the use of covariate adjustment with nonlinear models to estimate what are known as marginal or unconditional treatment effects. And the previous iteration of the guidance, it provided one example of a method known as G computation or standardization for implementing this. To clarify that that example was not necessarily prescriptive, we've also added additional discussion of other types of methods that could be used, such as covariate adjustment with inverse probability weighting. And then finally, we've added various clarifications and corrections throughout the document. So what I'd like to do now is provide a high-level summary of our guidance. One of the first sections is on general considerations. And probably the most important comment here is that a covariate adjusted primary analysis is acceptable to the FDA. And this isn't a new comment from us, and I think it's consistent with what other regulatory agencies have said in the past, but we did want to emphasize it here. It's by no means required. An unadjusted analysis would usually be acceptable to us as well. On pre-specification, as you might expect, we would want the covariate adjusted primary analysis to be fully pre-specified in terms of the model that would be used, how it would fit, covariates to be used, and so forth. So on the covariates to include an adjustment model, again, this is an area where we give sponsors a fair amount of discretion, including the discretion to not adjust at all. But as you heard, the covariates that provide the most precision gains are those that are most prognostic for the outcome. And in some cases, this might be known from phase 2 work or external studies or literature in the therapeutic area or other sources. So on the number of covariates, unfortunately, in reviewing the literature, we were not able to provide very precise rules of thumb for how many covariates to include in an adjustment model that we thought could be applicable across all of the different therapeutic areas that we review. That said, we do think that the properties of covariate adjustment are best understood when the sample size is relatively large compared to the number of covariates. I said a little bit earlier about stratified randomization. And then on change from baseline analyses, as you probably know, it's fairly common for the outcome of a trial to have measurements at different time points, including a pre-randomization baseline time point. And in this case, we think that adjusting for the baseline value of an outcome rather than, or in addition to, redefining the outcome as a change from baseline is usually something that's acceptable and has good property. So the next section of our guidance is about covariate adjustment with linear models, and typically this is implemented through what's known as ANCOVA, or analysis of covariance. And this can be thought of as a method for estimating what's known as the average treatment effect, or just the difference in mean responses between a treatment group and a control group. Now, if you didn't have any covariates, the simple estimator of this would just be a difference in sample means between treatment groups. With ANCOVA, you would fit a linearly squares regression of the outcome on an intercept and a treatment variable and a vector of baseline covariates, and then that treatment coefficient fit would be the estimator of the average treatment effect. And the nice thing about this is that it can be shown that at least asymptotically, this is going to provide valid estimation, even if one is not willing to invoke the usual textbook linear model assumptions like correctness of that linear functional form of the regression, or Gaussian errors or constant error variances and so forth. So in that sense, we do think of this as a reliable method that can generally be recommended. Now on standard errors, it is the case that if using the so-called nominal textbook standard errors that are reported in most software packages, you can get anti-conservative confidence intervals. So we do recommend use of robust standard errors such as Huber-White sandwich standard errors with ANCOVA. And then for our guidance, we think it's acceptable to either include treatment by covariate interactions or to not include treatment by covariate interactions in the model. Now, in some sense, linear models are a special case of covariate adjustment because it turns out that there's an equivalence between two different types of estimands. And so the subtleties of distinguishing them are often overlooked in this case. And these are what's known as a marginal or unconditional average treatment effect, which is the quantity that I just described, and what's known as a conditional treatment effect. And this is probably best illustrated with an example. So the table at the bottom of this slide is a hypothetical target population split into two equally sized subpopulations defined by a biomarker. The average treatment effect that I discussed is just this value in the bottom right cell, or just the difference in expected outcomes between treatment groups in the combined population. And here it's a 10-point difference. Now, in truth, there's no reason why the subgroup specific treatment effects would need to be equal to this quantity. But if they are equal to it, then that is termed a conditional treatment effect and is the value that's estimated by or you can also think of this as a value estimated by a linear model regressing the outcome on treatment and a biomarker. And kind of nothing unexpected here, the average treatment effect is 10. And if you have a constant difference of 10 in each subgroup, that's kind of the same value. So I'm going to show how there are a few more subtleties in other cases. So our guidance also discusses covariate adjustment with nonlinear models. And as a terminological point here, I'm including generalized linear models with non-identity link functions like logistic models. And these are often used when the outcome is not measured on a continuous scale, such as when the outcome is binary or ordinal or time to event. Here, before getting into recommended methods, we do think and say in the guidance that it's important to take a step back and ask for clarity on the estimand that will be the parameter targeted for estimation in the trial. And the reason for this, again, relates to this issue of collapsibility that's probably best illustrated through an example. So here is a table showing a hypothetical target population, again, split into two equally sized subpopulations defined by a biomarker. In each subpopulation, the treatment effect is an odds ratio of 8.0, but in the combined population, the odds ratio is 4.8. And this phenomenon is a little different from Simpson's paradox or confounding examples you've probably seen. It can even occur in a large randomized trial with a correctly specified logistic regression model regressing the outcome on treatment of a biomarker. So here, again, before getting into estimation, we think it's important to be clear with, especially clear with nonlinear models about whether the aim is to estimate the conditional treatment effect, which here is 8.0, or the unconditional treatment effect, which here is 4.8. So when the target of inference is a conditional treatment effect, such as the value of 8.0 for the odds ratio in the previous slide, these are the targets of inference for commonly used workhorse methods like logistic models or proportional odds models and proportional hazards models. And there may be some advantages even aside from familiarity. It was really interesting to read the comments that we received about our guidance. There's a little bit of a schism in the statistical community as some stakeholders preferred the conditional effects, whereas others preferred the unconditional effects. And of one possible advantage that was mentioned for the conditional effects was the fact that in some sense it might provide a more personalized or individualized treatment effect. So the main disadvantage noted by other commenters was that the interpretation can be a little bit harder to wrap your head around if one is not willing to believe a regression model, and specifically say in a model without treatment by covariate interactions, that there is going to be a constant treatment effect on the scale of the model across subgroups defined by baseline covariates. And in contrast with the unconditional effects, you can usually at least have a well-defined parameter that doesn't really require any of those types of regression assumptions. So the comment in our guidance is that sponsors should discuss with the relevant review divisions specific proposals and a protocol or statistical analysis plan containing linear models to estimate conditional treatment effects for the primary analysis. So when the target of inference is an unconditional treatment effect, such as the odds ratio of 4.8 in my previous table, our guidance comment is that sponsors can either perform adjusted analysis or unadjusted analysis. And as you've heard, the estimand is exactly the same in both cases. The hope is just that with covariate adjustment, we may be able to improve precision. For these methods, we think that they should provide or aim to provide valid inference under approximately the same minimal assumptions that would be needed for an unadjusted analysis of a randomized trial. And there are some methods that have been put forward for doing this with different types of outcomes. Earlier in my talk, I mentioned two classes of them called G computation or inverse probability weighting. And again, I won't get into any technical details here. They're maybe not the most widely known methods, but typically they do depend on fitting, as you heard in the previous talk, a working regression model, such as a logistic regression model, but this is used as an intermediate step. And then the final estimator of the treatment effect that's of ultimate interest turns out to be robust to misspecification of that model. And for these types of methods, we do think that standard errors or confidence intervals can be formed with an appropriate bootstrap procedure or with formulas justified in the statistical literature. Okay, so for my final slide, I do want to make some comments about data adaptive covariate adjustment. So the comment from our guidance on this is that sponsors should discuss proposals for complex covariate adaptive randomization, data adaptive covariate selection, or use of covariate adjustment in an adaptive design with the relevant review division. And I should mention that there is some literature on covariate adjustment when the number of covariates is large compared to the sample size, but there's variable selection implemented through regularization, such as the lasso. And there are some theoretical properties of these methods, but overall, we do think that this is in some sense an emerging literature, and the properties of covariate adjustment, as I said, are probably better understood in the opposite case, where the number of covariates is small compared to the sample size. So now consider cases where machine learning is used from an external study or external studies to form a prognostic index, and then that is then entered into an adjustment model as a covariate in a new independent study. So we actually think that this procedure does fall within the framework of our guidance, and that the method would inherit the property of valid covariate adjustment inference. And moreover, that this would be true even if the machine learning method itself was a black box method that was difficult to understand. Because once the rule for defining the index is formed, you can think of it as inheriting properties and being a special case of ANCOVA or other types of adjustment. Now, of course, the efficiency gains will depend on the association between the prognostic index and the outcome of interest in the new study. And this is really going to depend on how good of a job the machine learning is doing, as well as how well the setting of the external studies generalizes to the new study that will be conducted. So at this point, I will stop. And again, thank you for inviting me to this conference.
Thank you so much, Dan, for a very nice presentation. And with that, I think we would like to move into questions and discussion, Benjamin.
Thank you. I'm just trying to get everyone on screen. So if Courtney, you could switch on your camera, and Andreas, perhaps you come to the front so that we have everyone who was speaking present. And I'm just trying to figure out. So this should do the trick, at least. I hope you can see all relevant persons. Yeah, thank you very much for this very stimulating talks. I think that was really good. And before I open the discussion for everyone, I would want to kick it off with asking a question to everyone. So Courtney, you have shown an example on where you could improve. There's some echo. I don't know why. Could you try to mute yourself when you're not speaking? I'm not sure who it is. So the audio system was going to shut down. We didn't want to have that. Yeah, so the echo is gone as well. So yeah, but Courtney, you had shown a very nice example on where you could improve your model substantially by using your machine learning tool, your deep learner for the eye images. However, in principle, I'm not sure whether this is always the case that we can improve the models that dramatically. So my question to all three of you would, how easy do you think could one improve on clinical covariates by adding a super covariate, and what would be the purpose of doing so? So is the main purpose, in your view, the decrease in sample size? This is what is often advocated for by companies who try to sell these approaches. They say, well, your trial is much more efficient and we can gain power, we can decrease the sample size, so we spare patients and we spare money with that. Or is it a gain in power and we keep the sample size, or is it a gain in precision of the estimate, or is it a combination of these? And what would you advise on this? And perhaps we can start in the room with Andreas, and then I'll hand over to Dan and Courtney.
Well, actually, I would see it more to increase the precision and efficiency. So not so much to decrease the sample size, because I think decreasing sample size usually comes also with other disadvantages. So you have less safety data, and as I said, you have to do a benefit risk assessment, not only the primary analysis. So we have to do a subgroup analysis. So we need sufficient data for that. And of course, we may anyway have problems with subgroup analysis, but this does not depend on sample size. And of course, there may be other issues such as secondary analysis and so on that may also need to be considered. But of course, this may also depend on context, but usually I would not advise to decrease sample size to a large extent.
Dan, do you want to add anything from the FDA perspective?
Sure. So at the FDA, we do, as I said, give sponsors a fair amount of discretion in exactly how they want to size their trial, what assumptions they're making. But in general, I do think that there are a fair amount of underpowered trials, unfortunately. So at least my thinking on this is it's often a good practice to build some conservatism into sample size calculations, and there may often be advantages of sizing the trial based on an unadjusted analysis, but then using covariate adjustment to hopefully increase precision. I mean, of course, the danger of sizing the trial based on a planned adjusted analysis is that if that correlation with the outcome is kind of less than you hope for, then you may be in an underpowered trial. So I guess that's my thinking on the topic. Thanks.
Yeah, thanks. That's very good comment. And Courtney, do you have anything to add? I mean, it's difficult.
Yeah, I would just say that we liked that GA example because, I mean, often internally, we're always pushing for simple benchmark models for comparison, which is very important because, I mean, it is all about finding the covariates that are the most prognostic. We like that example because it's one situation in which you can use deep learning. Imaging data is a very good type of data with which to explore deep learning and these more complex types of models. So it is an example of where you can gain a lot more precision and power, both of those things, by using this kind of super covariate from a complex model. But you asked, are there other considerations besides just increases in precision and power, how much you get from, using a complex model, super covariate, versus just refitting the features. There is another consideration, which is the model budget. As I said before, if you're really tight, your sample size is small, then you can use the super covariate instead of putting in 5 features into a model when your sample size is only 100, right? So that's another consideration. I hope that answers your question.
I think that adds nicely to what has been said. I just would want to open the floor to others to comment on this or to also ask questions. And I'm aware that we also have questions in the chat, but I would first give preference to the room because you paid more and you're here.
David.
Thanks to all 3 speakers. That was fascinating and I learned a lot. So just a comment first. This sort of blows out of the water lots of conventional views in statistics, as you were alluding to from the 2015 guideline. All that very sound advice, well, I would say that because I was involved in writing it, seems now to be no longer, or some of it seems to be no longer relevant. And so I'm fairly convinced that's true, i.e. now you can develop a super covariate and there are no downsides. So is that really true? So it's always best to double check that. But if not, I presume the EMA will be revising the 2015 guideline as Courtney suggested. So I'd like that. Is that in the works to be done?
I assume this question was for Andreas, or was it?
So what's the question? I don't know whether I got it right. So whether it's time for the update or?
Yes. Is it time for an update or have we missed something? Is there any downsides to including super covariates? And shouldn't we just be doing that in every trial going forward?
Well, I think it would be a good thing to update and at least to reflect on these new approaches that we have and that we have a clear position on that. So I think that this makes sense. But maybe also one remark with regard, so I really consider this as an interesting example of what is called framing nowadays. How do we call these new covariates? So now we heard these super covariates, but while I use this term synthetic covariate, so and because this covariate does not have a direct meaning and is some way synthetically created. And so I think these different words are quite interesting in my view.
And I sense some provocative lines along your question. So it wasn't. I would assume that any such method would not be a one size fits all. I think there would be situations. That's my personal take as a chair and as a regulator as well. That there are situations where it might be beneficial, but it shouldn't be the solution for every problem we are going to tackle in the future. Do others want to chime in or to add something or? Courtney, Dan, any?
I'm happy to start. So I guess on the question of the super covariate and whether it should be used, across the board, I think you're right that there aren't downsides in the sense that it's going to lead to invalid, biased inference. To me, the only kind of real downside is kind of dealing with the increased complexity of the juice really worth the squeeze. A lot of that is kind of from the sponsor end rather than the regulatory end. I guess on kind of how much efficiency gain is possible, it really may differ quite a bit depending on areas. There's kind of a very nice example of working learning led to huge efficiency gains in an ophthalmology example. I can tell you that internally at FDA, we could look through some antibacterial drug trials to see how much gains were possible from covariate adjustment, and we weren't using deep learning, we were kind of more traditional approaches, and there it did not seem like there were kind of very, very large efficiency gains. So it might be somewhat of an empirical question that could differ from area to area, in terms of how much precision gains are possible from super learning or super covariance based on machine learning.
Yeah, thanks a lot. And I think it's also difficult in practice to know this a priori. So there will need to be a lot of work done for that. I give the next question was from the back row.
Yeah, thank you. Anders Gård Rasmussen, Novo Nordisk. Thanks a lot for 3 very interesting talks, also just seeing this together. Actually, it was one of your examples, Courtney, that got me thinking about, so you're speaking a little bit to the fact that that when you're calculating this EFSPI measure, if you have treatment effect heterogeneity, then you'll have a decrease, which also got me thinking about, even though you're training these models to produce, you could say, perfect prognostic covariate, you might end up in a situation where you actually produce a predictive covariate as well. And I'm just reflecting a little bit, and maybe I can hear the regulator's opinion on that. I mean, that would certainly complicate the interpretation if what you end up with is actually producing this covariate that's difficult to interpret, and you have treatment effect heterogeneity according to that. Can you reflect a little bit about how would that proceed if you end up having a model like that?
So I'm not completely sure. Was it for the regulators? Sometimes it's I'm sorry, it's a bit hard to hear in the front because somehow the
yeah. I think the regulator perspective on, okay, if you bring your model here and you actually end up having something where you end up having a predictive covariate instead, so you have treatment effect heterogeneity also according to this prognostic super covariate that you've built. Okay, then it starts to become complex also to interpret.
Yeah, so it's if the super covariate is not only prognostic but predictive. So this was the question. Andreas or Dan, who wants to go first? And of course, Courtney can add as well.
Well, yeah, maybe I make a start. Although I don't really have much to say what you already said. I think it really becomes challenging, and especially as this covariate is not really properly understood. So I think the relationships between whether it's really predictive, I mean, we don't have much data for that. I mean, we have it will be used only in one trial, so it's also a little bit difficult to say. So I think this is one of the downsides, that the interpretation can be really challenging in the end.
So I would just mention that if there is treatment effect heterogeneity, we just want to be aware of that because it will reduce the impact of covariate adjustment. Your standardized estimator is still consistent, right? It's still going to be estimating the marginal average treatment effect, even if your supercovariate is predictive. We just wanted to call attention to treatment effect heterogeneity just because teams should be aware of that if they're thinking about going crazy with reducing sample size, right? That's I think often when we say be cautious about reducing sample sizes, some folks wonder at that when you have, ESSI estimates of 100%, but we just want to let them know that, look, these estimates vary from study to study and can be impacted by treatment effect heterogeneity. For me, that was really the point, but there's no, issue for including a covariate into the model that is predictive.
Yeah, I think an important point you made is that we should be really careful in reducing the sample size. That we had last week at the SEN, and in the same venue here, we had a discussion around that issue as well. And there was also a rather clear preference of the speakers and also of the audience that we shouldn't reduce sample size because it might be just not based on a good basis. Dan?
Right, so I'll make a few comments. So for treatment effect heterogeneity, usually this is assessed, as part of a supplementary or exploratory analysis for which a trial is not going to be statistically powered. That said, if there is heterogeneity, and particularly if there's effect modification or the direction of the treatment effect differs across the subgroups, that does kind of raise questions about whether the average treatment effect reported in the primary analysis is really kind of telling the full story on efficacy that you want to communicate. So that said, I'm struggling with kind of how considerations related to that would differ for use of a super covariate rather than kind of a more traditional analysis of heterogeneity. I guess in one sense, it might simplify things if you have kind of a univariate prognostic index to just kind of look at subgroup analyses for that rather than a multi-dimensional analysis. I could imagine cases where subgroup analyses or interaction analyses by the super covariate would maybe be less interpretable with more traditional subgroups if, say, patients don't know kind of what subgroup they're in because they don't know the value of their super covariate, or if it's not something that would be kind of available to them at the time of decision making.
Yeah, that's a good point. Perhaps we can just bridge over to the question of subgroup analysis. And Andreas also mentioned in his talk that the Procova handbook gives words of caution to not use this, or that's difficult to use the supercovariate and subgroup analysis. And it's also perhaps a question to the audience. How would you see this issue? What issues do you see? I mean, we just discussed the predictive value of the potential predictive value of the supercovariate, but are there other issues you would see, and how would we proceed there? And I see someone in the back. Shall we?
Thanks, Alex Ocampo, Novartis. So thanks for the great talks. I think on the supercovariate, I just want to caution against the term supercovariate. I mean, I think it's just to avoid the hype. I've seen examples where supercovariates actually do worse than unadjusting, and I think we can all agree there's nothing super about that. So I think I prefer Andreas' term Procova, right? It's just maybe a bit more benign. But then I also have a question, and that is on this discussion of the conditional versus marginal estimands, right? So I think all talks pointed out that those things are different, right? When you have a prognostic covariate in your non-collapsible model, you're targeting a different estimand, and I appreciate Dan's kind of exposition of that. But more practically, when would you recommend to target a conditional estimand, and in what context would you recommend to target a marginal estimand?
Anyone wants to take this question? When to target a conditional or marginal estimand? And Courtney, you clearly said you're going for a marginal estimand, but perhaps, well, someone wants to comment.
Well, I'll just make one comment on maybe the kind of looking at the subgroups, or like looking at treatment effect heterogeneity with supercovariate. There are some, and also about the term supercovariate, we're not trying to say that this is like a new term. It's just some term we used for ease in the presentation to quickly say some multivariate function of covariates, right? You can use whatever. There's also the term Procova, synthetic covariate, whatever term you'd like. We're not trying to hype anything up here. It's just a term we used for ease in the presentation is all. And also about doing worse with an adjusted analysis. So if you have one-to-one randomization, as I showed with those formulas, you actually can't do worse asymptotically by adjusting for covariates. It is true technically in very unrealistic scenarios that you can do worse if you don't have one-to-one randomization, but not if you include treatment by covariate interactions. Then there's absolutely guaranteed that you do not lose precision via covariate adjustment. Now, on the conditional treatment effect, I just want to point out that there are some folks, I'm kind of thinking of Harrell and Steyerberg. I hope I'm not mischaracterizing their opinions, but there are some folks who think that, as Dan was saying, I think it's a really good point, who like using these multivariate functions of covariates for looking at treatment effect heterogeneity rather than going subgroup by subgroup by subgroup and looking for treatment effect heterogeneity there. So let's say you have a binary outcome and you have some predicted risk of that outcome for each patient, looking at the treatment effect heterogeneity on whatever scale you're interested in, whether that's the relative scale or the absolute scale, looking at treatment effect heterogeneity as you vary across that predicted risk of the outcome for the patients that are some multivariate function of multiple covariates. So there are some people who even prefer to do kind of subgroup type analyses or conditional treatment effect analyses using super covariates instead, or whatever, multivariate functions of covariates.
Thank you, Courtney. Khadija is next, and then I give also room for some questions from the chat. And I saw there's many questions, but perhaps we can have a selection then, and the rest we can answer as well online, so that people don't go unsatisfied. So we could perhaps try it. Khadija was first, and then.
Thank you very much to all speakers for fantastic presentations. This question is for Andrea. So you mentioned about the expectation is that any deviation from the standard approach of either an adjusted or covariate adjusted analysis to using synthetic covariates adjustment, that you need some kind of justification. And I'm just wondering, based on your experience, what does that justification looks like? If you could share, if you have some examples to share with us, that'd be great. Thank you.
I'm not sure are you referring to justify whether I want to use an unadjusted analysis or content-wise justification? So
in your slide number 12, you've mentioned that.
Okay.
In your slide number 12, you mentioned that you can have an adjusted analysis or adjusted analysis, but obviously if you have a synthetic control adjustment, then you would expect a justification for why this approach is being used. That's at least what I understood. And my question is, if that is the case, I think, what does that justification looks like based on your experience, if you have any examples?
Actually, I do not really have personal experience that it was ever applied in a real application. And I'm still not completely sure what slide 12 was, but I think it was this comparison to an unadjusted analysis and analysis with classical adjustment. I think it goes in the direction what Courtney presented. So doing an assessment, what are the expected gains in efficiency with what approach, and what is it really expected to gain a lot when it's added, or may I even lose something? I think that was meant in this direction.
Okay, thank you very much. That's very helpful. Thank you.
So there's one more question over there.
Thank you very much. I'm Jenny, and I work as a statistician in AstraZeneca. So thank you for these 3 wonderful presentations. I learned a lot from you. So we talk now about optimizing the model, right? But taking this one step further and linking this back to the rare disease that we talked about before lunch, when will we sit here and talk about the synthetic control group, and what is your reflection about how far we can take this technical field?
So if I understood correctly, the question was around whether we want to do not only using a synthetic covariate, but also using synthetic controls instead of real controls. Was that the question?
Yes, that is correct.
Yeah, so of course the idea is a natural next step when we would really be able to perfectly give a prognosis how a patient would perform under control, then we don't need an actual control treatment. But I don't see that actually. Not I mean, you never know what happens in the future, but currently I would just not do it, simply speaking.
And it's also perhaps a bit beyond the scope of the session. So
thank you very much for that answer.
Yeah, but it's of course a very interesting question. I give Dominic the floor. Perhaps you can have some questions from the chat.
Sure. Yeah, there's a question for Daniel about standard error estimation when estimating unconditional effects with G formula, for example. So I think you mentioned robust standard errors, but of course there's many different sandwich estimators out there. Do you have any recommendations for us on what we should be using there?
Right, thanks for the great question. So there are some comments in our guidance that I guess provide some fairly high level advice to use either kind of bootstrap methods or formulas that have been justified for specific methods in the statistical literature. And our final guidance compared to the previous guidance from 2021, we did want to kind of make clear that we weren't kind of recommending, one single method for standard error computation. Some lack of clarity about that in the previous version. I guess the only other comment I'll make is I just wanted to mention a paper from Ting Yi and her colleague from University of Washington, and her colleagues had a paper earlier this year on standard error estimation and using energy computation standardization methods for covariate adjustment with binary outcomes that had kind of some nice explicit formulas. Unfortunately, we weren't able to incorporate it in our guidance just because of the timing of the release, but that is something that you may want to look into.
Okay.
I think we can take another question from the chat.
Okay, maybe
I hope
another.
it answers the question, but I assume so.
So this one is for the whole panel. So it's the person asking the question has said that some speakers have stressed that the prognostic scores, the supercovariate, must be derived from historical data, but there are principled methods in the literature for estimating these things from the data from the same study, as long as appropriate techniques are used, such as cross-fitting. So does the panel have any comments on these type of procedures and how these would be seen?
Well, I guess the problem that we have with these approaches that as soon as we start using them, we usually have problems with type 1 error control. So this is why we propose, this is why external data is used. And I mean, the idea of all these approaches is really to preserve the properties of the analysis that we usually use. I mean, of course, you can always discuss whether you use other approaches, but this is then not within the scope of the approaches that we discuss here. And this really comes with a concern immediately with some concerns with type 1 error.
I think it's a very interesting area of research currently ongoing, and it's kind of new, and we're still learning, I think, the theoretical properties of using the data, the actual trial data, to come up with what covariates to adjust for. So I think it's interesting. I think if I could just say, even from a practical perspective right now, we don't really advocate for that, and we suggest using independent data just because of thinking of all of the added complexity from, using cross-validation and fitting a model using the actual trial data at hand, especially for a primary endpoint analysis, when your study reads out and there's this mad rush to QC the outputs and the code, do you really want to be running some complex cross-validation scheme as part of your primary endpoint analysis, right? That takes a lot of time and a lot of effort and adds burden to the team. So I think even from practical reasons, not the theoretical reasons, I think there's a lot of sense in using independent data.
That is a very fair point. And I think it's also to add to this, the question then of the pre-specification, you need to be very precise in defining what you would do when the data reads out. So I think this also all adds to this, but nonetheless, the cross-validation approaches and all that you need to use also for derive your super covariate, your Prokova model or whatever in the first place. And that you nicely showed also on your slides, that you cannot just estimate and validate the model on the same data set and then be sure that it's good, but you also need to be aware that you might run into overfitting when you estimate the model or the predictor on a separate data set. So I think it's still worthwhile to consider these methods. Dan, do you want to add something here?
I guess I would just reiterate the comment from my talk that if a sponsor has a method along these lines for more data adaptive covariate selection, I guess to come talk to us about the specific method.
While we are talking about the selection process and the complexities involved in this, do you have any thoughts on transparency? Andreas has mentioned it in his talk that he was considering it very important that we have sufficient transparency around how the model was derived and what components went into the model. And I think with all the complexity to try to understand this, it might be useful, but at the same time, we might not want to know it because, as Courtney has nicely shown, well, asymptotically, the model is valid regardless of what we plug in there. So perhaps we can have a brief discussion around that. And also, of course, from the audience, if you have any strong feelings, please chime in. I run.
Thanks so much for the great presentations. In terms of, I'm just putting a different hat on as a patient. So if I'm a patient, I would actually really love to know what my supercovariate is. Because if it is that prognostic, I really want to know what treatment response I will get. And so I really would like to get that published, and so that I can actually compute for myself, or with maybe some digital tool, what my supercovariate is. So that I can then also can see, okay, especially if there is treatment by supercovariate interaction, how much additional benefit I get. So I think there should be a lot of transparency around this. I think it probably would be even good to publish on that very early on, so that people can see, okay, this is a supercovariate, and this is probably not only a supercovariate for this specific study, but also for other studies. And because in the end, if you run lots of studies in this disease area, of course, I would expect that they use the same supercovariate and not something different, because otherwise it will be very, very hard to interpret the different results across different studies. So just some thoughts from kind of turning it around and putting on the patient perspective.
Thank you very much. And I think it's especially true for predictive biomarkers or predictive superscores, but also, of course, for prognostic variables. We might want to be interested in the conditional effect. Are there any further thoughts, comments?
Yeah. Oh, sorry. Was there someone? Dan, was that you or Andres? No. Okay.
I'm going to ask something to the speaker, sort of to say, but Courtney, you go first if you had a comment on the question on.
Yeah, I'll just say that these multivariate functions of covariates, it's not really about personalized predictions, right? We don't know. I mean, ideally, they are predicted outcomes of for these patients that have high correlations with observed outcomes. They don't have to be, right, in order to adjust for them. But it's not really about getting personalized predictions for patients so that they can assess, their own individual treatment effects. That's kind of a separate area of research. And we don't necessarily care for covariate adjustment, whether the models are even calibrated. Again, it's all about that squared correlation and much more to do with discrimination. So it may not be the case that your model is well calibrated. And also, these models are fit on clinical trial data sets, which, often where you could argue that really it's more of these kind of observational data sets that would be better to build a prognostic model on to get personalized predictions if that's what you're after. So I just want to be careful and make sure that, in my opinion, these two topics are distinct. These kind of personalized predictions and treatment effect estimation and covariate adjustment.
For the clarification, Courtney.
Yeah, I'm not sure that I would fully agree to that we can really have these separate, we can do this really separately. So, and I think one interesting thing and why these approaches are certainly useful, because when we develop these prognostic models, they certainly contribute to our understanding of the disease. And this is in any case a good thing. But the question is also, why do we want to have a justification, a clinical justification for including a covariate in a clinical study? This is usually because the assumption that a covariate is only prognostic. This may be sometimes true, but it's always always a suspicion that it may also be predictive. And so this is why we also want to have a subgroup analysis. And so I think it's really not sufficient to say, oh, I don't care about whether it's predictive and I only assume it's prognostic. So, and this is why it's also useful to have some kind of understanding. And so I would also agree that it would be interesting to do some kind of a subgroup analysis or kind of that. So of course, I wouldn't go so far to personalize it in an extreme way, but to go in this direction, I think it would be certainly useful.
Yeah, so I just wanted to ask, and maybe going back a bit to David's earlier comment, the potential dangers or pitfalls here. I mean, you're all quite cautious, I think, about reducing the sample size, sort of saying, okay, we can gain so and so in efficiency, so we reduce the sample size. If you don't do that, so if you do what many of you said, that instead you maybe keep the same sample size and try to gain precision, are there any real dangers then, or is it really a rather safe approach? I mean, you showed, Courtney, that you sort of worst case scenario, you're back to the unadjusted analysis kind of so, or do you see any big dangers beyond that if you keep the same sample size?
We view it as relatively safe, yes. But I don't have much to add beyond what I said in my talk, I suppose.
So it seems like a free lunch, what you described. That looks nice.
Yeah, but I think I would not, I think it's really difficult, because I think it's really the question with this interpretation. So because as I said, it's not only about the p-value of the primary analysis that we should be concerned about. And I think here it's really important to differentiate, of course, when we talk about these unconditional treatment effects. I think there we have, for the primary analysis, we have less concerns. But as soon as we talk about conditional treatment effects, I think we really need to understand on what we condition, because otherwise we don't understand what we estimate at all. And even with these unconditional treatment effects, I don't know, actually, it's not clear to me whether we really have a problem with bias in the subgroup analysis, or whether we should go to another model for subgroup analysis, and whether this would lead to difficulties with interpretations. So I think we should be more careful before we say it's completely without risks.
But perhaps you can probe us, so you can test it, you
yes,
can show it to us, and then we will all learn. That's perhaps
this would be very welcome.
Can go ahead if you want.
Sure, I just want to quickly go back to the question, if I understood it correctly, there's any danger of sizing the trial based on an unadjusted analysis, but not forming adjustment. And I would agree that, you know, usually that's a fairly safe practice. The only caveat I would give is that if you have a covariate that really is extremely prognostic, like shown through the ophthalmology example, then you could be dealing, I guess, with an overpowered trial if you base it on the unadjusted analysis, which sometimes really with, you know, ethical issues as well, that you're kind of exposing more patients to a treatment than that is actually needed to obtain a reliable answer about the treatment effect. But usually for the types of covariates I've seen, I consider it a fairly safe practice.
Is it a comment to this or is it a further question? Alexander, please.
A further question, actually. One comment first, there's definitely no free lunch because you need to collect all these kind of different covariates, and you need to make sure that there's nothing missing and all these kind of different things. So there's no free lunch. What I'm asking about is, what about errors in these covariates? So if you there's certain things that we can pretty precisely measure, like gender, age, but there's lots of other covariates where we actually have quite a lot of variation and errors in the covariates. What's the impact of that, and what is the impact if in our data sets that we take this from, we have a different error in the covariates than in the clinical study?
I think this is a question to you, Courtney. I would assume that you're the best person to answer that.
Yeah, sure. So I think I showed in the talk that, you know, I showed nicely how we assessed the effective sample size increase or the squared correlations across multiple studies, right? That were completely independent, some of them not even used at all, partly in the model development. So it is really important to get a sense of study to study variability in these effective sample size increases estimates. I think that's important just to know that when you go on to an independent trial, your ESSI estimate could very well be bigger or smaller than what you've seen in any particular trial in your independent data. So yes, that it could be that, you know, there's more or less error, different error in collecting covariates in upcoming trials, but you kind of just expect this in terms of the variability in the ESSI estimates from study to study.
Thank you. Uli?
Maybe a comment and a more general question. The comment is, whenever I think about it, I don't find a really good reason why we shouldn't do it. And I think when we wouldn't do it, we need to have a good reason. I see the additional complexity, also the cost when we have a really complex prognostic or synthetic prognostic factor in sampling all that data. That could be sort of the non-free lunch. But there's one thing I'm a little bit suspicious, and that is how long could we use such a score? Usually I like it when we build it on external data, but when we do the trial, external data are historic data, and historic data age. And we should have a good feeling for what is actually the aging process on my prognostic score. How old can the data be that they still make sense? And with change in standard of care, with change in treatment, I think the prognostic value could change, could fade away or whatever. And I think it would be good to know about that aging effect.
Yeah, thank you. That's a good comment. Are there any? Oh, sorry. Elina, please.
I had kind of a similar comment, but from a different angle. That then, would you then think that if such a model has been built, for example, you at Roche Genentech had a really nice data set, so would maybe not be shared and published to make individual patient level decisions, but to be used in the same area for drug development in general? So would that kind of become a standard to be used, because maybe not everybody has the same data set, or if everybody builds their own model in the same indication, that also raises questions. So maybe that kind of generalizability, but not necessarily to patient level decisions, but clinical trials in that same indication. And then of course comes Uli's points then too about how does it age?
And this was also addressed by Alexander before. So the question of could we use the same score for all trials so that we can compare results? There's another question or comment over there.
Yeah. Okay. Yeah, Nicolas Valerini from Novartis. Maybe a question for regulators. I was wondering, how do you ensure that all the analyses that are done on external data to define the super covariate can be pre-specified? Usually, you could specify in an SAP that you're going to do some machine learning, and there is always one parameter that you can change, and it will completely change the variables that are selected or the coefficients. So how do we ensure that this can be pre-specified and then there are no further changes?
Well, if I understood it correctly, I think you pre-specify that you use this synthetic covariate. And then you have to make sure that this covariate is correctly calculated, right? And I think this should be able to be pre-specified if the model is transparent. So otherwise, it could be difficult, but I don't know whether is it what you were addressing, or?
Yeah, but now we have a lot of machine learning algorithms, random forest, and lasso, GLMNet. You put all together and you use the super learner that combines several learners from different machine learning methods, and then it's really impossible to track what's the contribution of each variable into the final super covariate. So, yeah.
This is perhaps a bit the question also why we would need to have transparency around these super learners, so that we understand what is planned and in how far it was really, if we followed this pathway, or whether we had some magic happening in between. Yes, please.
Thank you. Yeah, actually, it's two comments, but brief. First of all, there is an area called interpretal machine learning, which could help to see what variables are included in the super covariate, or however you call it, and to interpret that. So yeah, this is one comment, but the other comment, it is known from other contexts that small perturbation of data can lead to completely different conclusions in machine learning. And I see kind of a risk here. That is another comment. It may not happen very frequently, but sometimes it does. And I think more research is necessary to identify when does this happen. It could also apply to super covariates.
Yeah, thank you for these comments. And we are above the hour, so we don't want to stand in the way of the wine tasting and you. So I would really want to thank everyone for this engaged discussion. It was really great. And of course, a special thanks also to our colleagues from the US who made it for us so early this morning. Thanks a lot and have a good rest of the day.
Thank you very much.
Thank you.
Before we leave the room, just wait a little bit. There are a few instructions needed for the wine tasting. Unfortunately or fortunately, the wine is waiting outside of you. There will be enough wine, so don't worry. To be honest, the main thing is, of course, just to continue the discussion we had, the networking, etc. But in order to make it more fun, we have a little bit of a national competence there. We have two sorts of red wine, two sorts of white wine, white red from Germany and white red from France. And in order to make it more interesting, there's a competition who will have the best wine. We already defined a metric for that, and that is the wine which is mostly consumed wins. So that's very easy. You will see us now that you have to contribute to that. I believe that when you're interested in soccer, yesterday evening that the two national soccer teams already gave good prediction for
very poor.
But judge yourself. There will be enough classes for everyone, but reuse the class. We don't have so much classes that you can get for each wine a separate glass. Otherwise, just take a bit of a sip of water and clean. Just a few things, the German wine, and then I hand over to Emmanuel before he gets totally nervous. The German wine is locally from the region, maybe 30 kilometers north. At the basic of the Black Forest. Called Pritzingen, nice little village. You can go there, walk a lot, really nice, lots of vineyards, try it out. And now I hand over to Emmanuel to explain the French one.
Thank you, Lee. Yesterday's football match, by the way, was a friendly encounter, right? Just wait for the true competition. So the French wine will also allow you to know better the area because the white wine is coming from Alsace. It's a Sylvaner from Alsace. While the red wine is coming from the south. So you can imagine the beautiful southern blue sky. And interestingly, it's a French wine done by a German woman who decided she had to move to France to do proper wine. Right? An interesting feature of the French wines, if I may continue, is that after a long day of a statistical congress, if you read the safety section of the label, those wines don't give headaches. And I'm not kidding. You can drink as much as you want. You can mix them. They don't give headaches. And for one reason, they don't contain only infinitesimal amounts of sulfites. So they are a bit original wines, but very drinkable, very digestible.
I think Emmanuel goes a little bit beyond the SMPC here.
It's a controlled label based on data. I tested it. So 3 rules to follow for this little experiment. So it is, as you understand, a pragmatic open label trial. We count on your equipoise to test all the wines. But then we count on you to follow an adaptive allocation design. That is, you go back to the one you prefer, right? So this is how it works. We define the endpoints. Now, the rules to follow. So first, you keep your glass. You may have 1 glass for the red, 1 glass for the wine, but you please keep your glass and you bring it back to the table where you took it. You have 2 sorts of glasses. Second, you never leave your glass empty too long. And the way to address this is to do this gesture, right? So to get a refill. The third rule is you never leave your glass full too long. And the way to address this is to do this, right? So if you practice, you'll see it's very easy to follow, right? So with this, we just invite you to enjoy. The wines are there and enjoy the time together.